Yes, now the recording is started. So I hope now you have a little idea that what is coming in this session. This is extremely important, guys, because nowadays hospitals are having antimicrobial stewardship committees and they are hiring pharmacists in the AMS committees, right? So we have simultaneously also the course which is running for the 6 month antimicrobial stewardship, and many of you are already in the AMS, course. So those who have enrolled themselves into the AMS course might be aware of this microbiology report little bit because in the yesterday session we have discussed. But if it is new for you, still you will be having lots of things in this session. So don't worry if this title feels new to you, if the concept feels new to you, because we will be starting from the very basic level and we will be seeing that how exactly you should read antibiogram, what is breakpoint, what is MIC, how you can interpret it, all the things we are going to discuss today. So, this lecture is not going to be theoretical. It is purely the clinical side and it is purely practical side we will be talking. And we will dive deep into this matters. Okay. So, we will see antimicrobial susceptibility test as well, AST also, and how to read it, what to interpret, and how to connect with our therapeutic interventions. That is the topic of the discussion today. Okay. So I hope what is coming is clear, and now you are ready to deep dive into the slides. Okay, just a minute. I'm sharing the screen. I hope the screen is visible to you. Is it? Okay, just a minute. So this is the title: Microbiology Report and Antimicrobial Interpretation. This is the module number 5 of our whole laboratory medicine course, and extremely important I will consider. Extremely important topic in the today's world, and in the current scenarios you might be having idea how big stewardship concept is, and this is the emerging concept in the pharma, and the resistance is the reason behind it. Resistance is widely becoming a threat to the healthcare, right? And you might be knowing that our prime minister Narendra Modi is also in that one of the in his one of the speeches he said about antimicrobial resistance, and he also said about ICMR and all, right? So what is the level of resistance we are having in the healthcare? That is very huge. Bacteria are evolving, viruses are evolving day by day, and to match those, their speed of evolution, okay, that is very we can consider it is very much impossible thing, right? Because this is not about we don't have enough drugs, but you know that what is the drug development process. We have more than 5 million billion molecules with us, but only 1 to 2 is reaching to the market, right? After so many of preclinical trial, clinical trial and all. So lots of things are required, lots of money is involved, lots of time is involved to a molecule to reach the market. And even after in the coming, even after coming into the market as well, post marketing surveillance is going on the many molecules. And after coming in the market as well, withdrawal happens. Many examples we have in our therapeutics, that after coming in the market itself, the drug is being withdrawn because of the post-marketing surveillance. So these are the very risky things, right? And drug development process is the very important concept to understand. But at this point, we need to understand the severity of resistance and how exactly the resistance is being identified by the microbiology report, by the antimicrobial interpretation. How to read antibiogram, what is exactly indicates, that is the topic of the discussion today. This is a laboratory thing and the report is coming from the lab itself, but we need to understand how to read it and how to interpret it and how to correlate it. Okay, so let's understand why this lecture matters for the pharmacist. So, uh, it is very important to understand. Many students, generally ask me that why should pharmacists study microbiology reports in so much detail? Why? What is the need? Because we have separate skillful, persons, and we can say a healthcare team which is responsibly, dedicatedly work to this thing. So why pharmacists are important, playing an important role while handling microbiology reports? So the answer is very simple. Antibiotics are most misused drugs in the hospital, guys. Okay. So antibiotics are most misused, I will say. If the antibiotics are overused, resistance developed. Okay. And this is the real scenario, everyday scenario. And that's the reason why we are having the threat in the healthcare. That is the resistance nowadays. Also, if antibiotics are underused, it is treatment failure risk. If it is used wrongly, patient's condition may be, further deteriorate. So as a pharmacist, our sole responsibility is to ensure that right drug with the right dose, with the right duration, right indication, the 4R. Okay, right drug, right dose, right duration, right indication, also I will say at a right cost. It is reaching to the right patient, and all of this starts from the correct interpretation. We are aiming for this right, which is practically, I will say this. If I say this right drug, right dose, right duration, right indication, what does it mean? It is you. It is means this is a rational use of the drug, quality use of the medicine. But practically, guys, it is not every time possible to select the right drug, right dose, duration, indication at a right cost for the patient. But this can be our goal. Okay, this can be our goal, and we can do a lots of things to match our goal. Okay, so we this antimicrobial stewardship has very clear goal, that is this. Okay, rational use of the medicine. So all this rational use starts from what thing? It is starts from correct interpretation of what? Microbiology reports. Okay. For example, a doctor may see a bacteria which is isolated. Let me give you a simple example. And start a very strong antibiotic. A doctor can see this bacteria is isolated, for example, E. coli, and start a very strong antibiotic that can act, for the E. coli. But you may notice that it is actually a contaminant. Okay, and your intervention can further prevent unnecessary use of, antibiotic and toxicity and resistance further. So this lecture is for this type of fundamental thinking, to build your clinical confidence while handling the reports. Okay, so why this lecture matters for pharmacists? This is the key role in antimicrobial selection. Pharmacists are having key role in the selection of antimicrobials. They are preventing resistance, as I already give you the example to understand this sentence. They are supporting stewardship. Stewardship means right drug, right dose, right duration, right indication. Stewardship generally means a monitoring of antimicrobials, guys. Okay, and also the stewardship has goal of rational use of the drug. And what do you mean by rational use? That is right. Okay, right drug, right dose, right duration, right indication. Okay, so support stewardship ultimately, if you know how to read it, and it improves the overall patient outcome. Obviously therapeutic outcome will be increased. Okay, it will be improved if you are practicing this. So that is the importance of the lecture. This is the importance this topic is holding, and that's the reason I told you that this is the, you can consider this is the heart of the whole, we can consider the whole course, right? Someone want to speak? Yes or no? Okay, so I think that is by mistake. Okay, no worries. I will give you access if you want to speak at the end, guys. In between, if you have doubt, if you have suggestion, you can put into the chat box. No worries. Okay, we will discuss at the end. Okay, so let's start. I think why is clear now. Let's jump towards the learning objectives. So how to, what to expect by the end of this session. So before we go ahead, let us be very, very clear about what you should be able to do after this lecture. So very first, by the end of this session, you should be able to interpret the gram strains. That means you look at a gram stain report and understand what type of bacteria is present, whether it is gram positive, negative. Okay. Also, by the end of this session, you will be also able to understand the culture reports. So you will be able to read understand. That means you will be able to read the culture report and you will be able to identify whether it is significant or not. Okay. Also, you will be able to understand what is the use of MIC and antibiograms by the end of this session. MIC means minimum inhibitory concentration. Okay. I hope many of you might be knowing this. Many of you might be not knowing this. If no, then please understand MIC is minimum inhibitory concentration. The meaning itself, it is in the full form. Minimum concentration of any antibiotic which is required to kill the bacterial growth. Now, guys, जब भी laboratory से report आता है ना, तो उसमें जब भी antimicrobial susceptibility testing report आता है, तो उसमें clearly लिखा हुआ आता है that for this microorganism, this MIC value will be effective. Okay, so MIC means minimum inhibitory concentration. What is the process of an happens in the laboratory? That is, they are collecting the sample. Okay, they are collecting the sample. They are growing the bacteria into the petri dish in the laboratory. Once the growth is happened, they will be using some antibiotics as a in the growth area, and they will drop it, and they will see further what happens. If they will examine the changes. If they are finding that it is becoming less, the bacterial growth is becoming less, your antibiotic is susceptible, it is sensitive, that means your antibiotic is working. Okay, if your growth is not stopped by the antibiotic, again it will be resistant, that is R. Okay, so antibiotic report में क्या आता है, SR लिखा हुआ आता है, susceptible and resistance mention किया होता है. Okay, I will show you some real reports as well to understand how exactly the report is look like, and you will be also able to understand the interpretation. Okay, susceptible, resistance. One more interpretation is there, which is intermediate. So that means intermediate means you may use it, you may not use it. Okay, so some antibiotics are there which is in the 50-50 position, that yes, it can cure as well, it cannot cure as well. So that is intermediate category. Okay, and it is also the lab report has also MIC value, that is minimum inhibitory concentration, at lowest possible drug dose. Okay, lowest possible drug dose which can be useful to kill the bacterial growth, that is MIC, so that you can obviously avoid toxicity, right? So these all are the things are mentioned in the report. You will be also able to use this MIC and antibiograms. Guys, antibiogram is the report. It is having all of the things all together. I will show you in the upcoming slides. And also you will be able to apply to this all the things to the clinical cases, because we have three cases we have to discuss today, so that it will be clear to you. Okay, you will be able to apply in the UTI, bloodstream infection, multi-drug resistant infection and all, and you will correlate by understanding the cases. So these are the learning objective for the session today. I hope it makes you more curious, because these are very important topics. Okay, so let's start. We will be saying first the microbiology workflow. So what is exactly the workflow? How exactly it is being done? So I simply, told you the workflow in the previous slide, guys, how exactly it is happening. So let's just understand the complete journey of the microbiology report. Think of it like a chain, okay? Like a chain. So if one link is weak, the final decision will be wrong. Okay. Very first thing is the sample collection. Sample can be blood, urine, sputum, CSF, it can be pus as well. Okay, so cerebrospinal fluid, that is CSF. So sample collection is the first step. Second is a gram strain, that is gram strain, that means direct microscopy. So it is done directly on the sample. It gives you a preliminary idea within the few hours only. Okay, few hours में ही इसमें थोड़ा बहुत idea आ जाता है. Third step is culture. Now they are growing the microbes, the bacteria into the laboratory. So sample is placed on what? Culture media, and the organisms are allowed to grow further. That is culture and identification. You can consider step 4 as an identification. Sometime it is written, you know, in one line as well. So identification is nothing but the organism name will be confirmed by the structure and all. Don't deep dive into this thing, because we have microbiologists and lab technicians to perform these things, but we should be able, we should aware at least that what is exactly the workflow. Okay, that's the reason we are understanding it. Once the culture identification is done, you will be having AST, that is antimicrobial susceptibility testing. Now, this tells us which antibiotic will work and which will not. See the name, antimicrobial susceptibility testing. Susceptibility means its capacity to kill the bacterial growth, and antimicrobial means you are using certain antibiotics, antimicrobials, to kill the whatever the growth you are having in the petri dish. And that is the main report, AST. And finally, the report is released. Okay, final report is released to the clinician and the pharmacist. And as a pharmacist, we mainly act at the step 5, guys. दैट इज द रिपोर्टिंग. ओके, सो एक बार रिपोर्ट हाथ में आ जाए उसके बाद हमारा काम शुरू होता है. तब तक हमारे पास और हेल्थ केयर की ब्रांचेस है जिसके लोग काम कर रहे होते हैं. ठीक है, इसके ऊपर माइक्रोबायोलॉजिस्ट वी हैव, लैब टेक्नीशियंस वी हैव, लॉट्स ऑफ पीपल आर वर्किंग ऑन इट. सो दिस इज नॉट आवर एरिया ऑफ एक्सपर्टीज, बट yes, how exactly it should be, it is happening, that should be in our head. Okay, so we must understand the step 1 to 4. Main work is begin by the fifth step, and we are reading further what exactly the report is all about. But I hope microbiology workflow is clear to you, from sample collection to making a report. Now, what is the importance of sample collection, guys? Because one single mistake in the sample collection, it can lead to a different report, right? A whole different report. So I want you to remember this line: wrong sample is equal to wrong report, and wrong report, that means wrong treatment further. And trust me, guys, when I say this is happening in the world. Okay, this is happening in the daily scenarios. So let us take the one example, like blood culture ka example lete hai. So if the blood is taken, after antibiotic, the patient is not informed. And what happens if the patient is taking antibiotic and then giving the sample as a blood? What will happen next? Bacteria may not grow in that sample, right? So result will be what? No growth, but the patient actually has the infection. So this is very important. For an example, urine culture. So if the midstream urine is not collected, skin bacteria contaminate the whole sample. What will happen next? False infection will be there in the report. Okay. Same goes with the sputum culture. If the saliva is collected instead of sputum, what will happen? Lab grows what? Oral flora, right? And report becomes again meaningless. So whenever you see a microbiology report, always ask, when was the sample collected? What antibiotic already started? Does the report match to the patient's symptom? The last question is very important. Does the report match the patient's symptoms? Very, very important. If the patient is having sign and symptoms, right, so you must correlate your report with it. Many time क्या होता है, वार्ड राउंड के टाइम पे या हम केस कलेक्ट कर रहे होते हैं उस टाइम पे, हमारा जो रिपोर्ट है, वॉट एवर रिपोर्ट वी आर हैविंग, दैट इज नॉट मैच्ड विद द क्लिनिकल पिक्चर. Many time it is happened, right? So always ask yourself, there is always a chances of errors in the handling process, guys. Okay, so reassure करना, रीटेस्ट करना बहुत जरूरी हो जाता है, rather than only guessing it and going forward with the therapy. So you must be clear with the chances of errors, and that is the reason I have put this slide in the module. Importance of sample collection: correct timing, aseptic technique, adequate volume, clinical relevance, everything is making sense in the sample collection. Just have a thought in mind that we have lots of chances of errors if one single step in the chain is not correct. Okay, so importance is very important to consider. Now let's start with the introduction of some gram stain for understanding the report. So gram stain is the first microbiological clue, whatever we are getting, first and fastest microbiological clue. Okay, so it is very rapid, it is cheap as well, and it is very useful in the case of emergencies. Once you know gram positive, gram negative, you can choose the antibiotic based on that. Okay, so it does not tell us exact organism. Of course, it is not telling us that whether it is E. coli, whether it is Staphylococcus aureus, no, but it can give you idea about this, differentiate the bacteria based on the cell wall. Okay, so it does not tell us that exact organism and antibiotic sensitivity, but this gram stain is telling us whether the bacteria is gram positive or negative, and the shape of the bacteria it can give you the idea about. ओके शेप, एंड शेप जो है बहुत सारी चीजें डिफाइन करता है आगे, ठीक है। सो इट गाइड्स अर्ली ब्रॉड स्पेक्ट्रम थेरेपी, एम्पिरिकल थेरेपी गाइड करता है, एंड दिस इज वेरी इंपॉर्टेंट, इट इज रिजल्ट्स अवेलेबल विद इन आवर्स। नाउ टाइमिंग इज वेरी इंपॉर्टेंट, it gives you idea in very less time, and that's the reason in ICU or sepsis cases, gram stain often guides the first antibiotic choice, guys, even before the culture results, even before the culture results. So next time, if you are in the ICU rounds, and if you are seeing the sepsis cases and where the culture report is still under consideration, you can focus on the gram stain report. Okay, it will be there. Okay, it will be there. It is compulsory, and within hours, sometime hours भी नहीं होता, half an hour में gram stain का report आ जाता है, which gives you idea about whether it is gram positive infection or gram negative infection. What is the shape of the bacteria? Okay, so based on that, you can interpret further, and then you can choose your therapeutic regimen. Okay, so obviously it is not the ultimate thing. We require culture result to treat exactly, disease specific treatment के लिए we need the culture results. But in case of an emergency, of course, it is very important. So first you need to understand this gram stain report. Okay, let's understand what is the principle of gram staining. So gram staining is based on the bacterial cell wall structure, guys. Cell wall structure. So let us understand the steps, in detail. First, crystal violet. Now stain, it is staining the all the bacteria purple. Okay, crystal violet. That means it is staining all the bacteria in the color of purple. Then we mixing the iodine that fixes the stain inside the cell. Cell के अंदर stain को fix करेगा. Then you will be using alcohol, which is not written here. Alcohol decolorization, second bullet point. See, this is the most important step. It is removes the stain from the bacteria within the thin cell wall. Okay, it is removing the stain, and then you will be having a saffronin. Saffronin is a counter stain, guys, and it is staining the decolorized bacteria to pink. Now, if you are not having this mechanism clear, don't worry. Just understand the principle of gram staining. uh, Understand that some add-ins, some crystal violet iodine and these colors are being used to identify the shape of the bacteria. Okay, and what is the simple process? First is the violet to stain the bacteria purple, then we have iodine to fix the stain inside the cell, then we have, this is the primary stain. Okay, if the once the patient once the bacteria is having the iodine, it is giving you the primary stain. Then you will be using alcohol. This is the most important step. It is removing the stain from the bacteria within the thin cell. Okay, and then you will be using saffronin. Now this is a counter stain, it is opposite act. Okay, act oppositely, and it will be staining a decolorized bacteria to pink. Final result, what you will be having, a thick peptidoglycan wall that retains the violet color, that shows you gram positive. Thick peptidoglycan retains violet color, that suggests you gram positive, and thin wall that loses further the violet and turns into the pink lastly, that shows you gram negative. But see, first traditional practice में क्या होता था, only purple color and pink color was written, was used to be written in the report. So we need to interpret. But now the modern reports are already have these things, and they directly mention that what exactly the bacteria is, whether it is gram positive or negative. So, okay, but still you need to be aware of the principle. Some violet iodine colors are being used, then alcohol is being used, saffronin is counter staining. If it is remaining violet in color, it is gram positive. If it turns in pink, it is gram negative. So the difference is why antibiotic response is differs according to this. Okay, so if the gram negative infection is there and you are using antibiotics which are working for the gram positive bacteria, what will happen next? Resistance, right? So this is the principles you need to be aware of at least. Okay, don't need to mug up, don't need to memorize this thing, because as I earlier told you, modern report is already coming with the name. Okay, gram positive and negative in the gram stain, but still you need to be little bit, you need to have little bit idea about how exactly the gram staining is happening. Okay, now let's dive deep into this gram positive bacteria appearance and meaning we will understand. So as I told you in this slide, that gram positive will be in the violet shade. okay, a purple shade. So this gram positive bacteria appears purple or blue or violet under the microscope, okay, clearly visible. So we have some common patterns, like you will be having cocci in the clusters, that will be showing you staphylococcus. Okay, you will be having a cocci in chain like structure, that is giving you again streptococcus and enterococcus example. And if you have rods in shape, that is bacillus or clostridium. Okay, but this is the duty of microbiologists to interpret. That's the reason I have not include these examples into the slide, but for your understanding, I'm just elaborating the things. Okay, but at your level, just understand gram positive bacteria appears purple color. Examples we have cocci and bacilli, staphylococcus, streptococcus. Okay, so cocci in cluster अगर होता है तो वो होता है staphylococcus. Cocci in chain अगर होता है तो वो होता है streptococcus or enterococcus. Okay, and bacillus is always in a rod shape. As I earlier told you, this gram stain is giving you the shape of the bacteria. और shape से भी बहुत कुछ decide होता है, ठीक है. So if rod shape लिखेगा तो that is bacillus and clostridium. Okay, so this is how you can relate. And what is the clinical relevance, guys? That is very important. So what happens? Many gram positive organisms are sensitive to beta lactams. Okay, gram positive जो होता है पर्पल कलर का जो दिखता है, those organisms are sensitive. Sensitive means beta lactam medicines will be effective against gram positive. But methicillin resistant staphylococcus aureus MRSA, that is the resistance pattern, that is exception, उसमें beta lactam काम नहीं करेगा. So seeing what gram positive cocaine cluster immediately makes us think that could this be staphylococcus aureus or something else. That is how interpretation begins. Don't worry if you are not able to understand it, because in upcoming slides we have these things in detail how to interpret. For now, understand gram positive bacteria. And gram negative, on the other hand, that we have pink in color, which turns pink. Lastly, it appears in the microscope pink. We have some of the examples. We have bacilli, we have diplococci, we have pseudomonas, klebsiella, E. coli, acinobacter. These all are the examples of gram negative. E. coli is one of the major one. I hope you have idea about it, right? So why gram negative infection are dangerous? Because they have an outer membrane in it. Gram negative is dangerous as compared to gram positive, guys, because they have an outer membrane. Bacteria itself, they have outer membrane, and they contains endotoxins in it. Very huge level पे होता है, ठीक है? They are containing endotoxins, and gram negative is also developing resistance quickly as compared to gram positive. Okay, that is also one of the factor to understand. ये भी एक comparison है छोटा सा to understand कौन सा infection ज्यादा danger है to treat. Okay, so gram negative अगर है, then again you will be having little bit extra caution to deal with. Okay, so gram negative sepsis is more severe as compared to gram positive conditions. So this is about gram positive and negative. Now let's correlate with the clinical things, clinical relevance of gram stain. So let us connect gram stain to the treatment now. This will help us to narrow down your antibiotic choices early. Okay, of course, if you have idea about gram positive and negative, you can narrow down your antibiotic choices. For an example, we have gram positive cocci in cluster, gram positive bacteria, cocci in cluster, that is considering and staphylococcus, as I earlier explained you this thing. So of course you will be thinking staphylococcus, and it is written in the report, and it covers MRSA in some condition, in some conditions. Okay, this is how you can relive, you can relate your report to your clinical choices. If your report is suggesting it is gram positive cocci in cluster staphylococcus, so you will be considering anti-staphylococcus agent for this treatment. If your report is showing gram negative bacilli rod shaped bacteria, right, gram negative, and you will be thinking like, yes, there can be the possibility of enterobacteria, right? So you will be choosing what? Gram negative coverage antibiotics, broad spectrum gram negative coverage, and that can be beta lactams, that can be carbapenems, right? So you are choosing this. So based on your report, you are making the decision. That is the clinical relevance of gram strain. Okay, but always remember, guys, gram stain guides the therapy. Okay? It does not replace the culture results. As I earlier told you, we required culture results. Gram stain जो है सिर्फ इतना बताता है कि शेप ऑफ द बैक्टीरिया क्या है, पॉसिबिलिटी ऑफ द बैक्टीरिया क्या हो सकता है, एंड कौन सा स्टेन है, इज इट नेगेटिव और पॉजिटिव. सो इन इमरजेंसी कंडीशन एंड ऑल इट इज वेरी यूजफुल, बट इट इज नॉट अ रिप्लेसमेंट ऑफ द मेन कल्चर रिपोर्ट. We need culture report. What are the limitation of gram stain? Let's understand. So, up to now, we discussed how useful the gram stain is. But as a clinical pharmacist and future pharmacist, we must understand its limitations as well. Okay. So, first limitation, gram stain cannot identify the exact organism. It can give you idea, it can give you direction, but the exact organism it cannot find. Okay. It can give you idea about, for an example, gram positive cocci in the chains. But gram positive cocci in chain can be Staphylococcus pneumoniae. It could be Enterococcus as well, and some other bacteria as well. Okay. To confirm what is the bacteria exactly, you need culture results. You need culture results, right? So this is the first limitation. It cannot identify the species. It can give you general idea, gram positive cocci in chain or gram positive cocci in cluster. Okay, but it can be many. Okay, so that is the very first limitation. Second, it is having a low bacterial load, low sensitivity if the bacterial load is low. So if bacteria is very few, if the in the sample collection the bacteria is very few, load कम है, तो क्या होगा, ग्राम स्टेन दैट मे बी नेगेटिव, पूरा नेगेटिव ही आ जाएगा. ओके, बट द कल्चर लेटर, कल्चर रिपोर्ट व्हेन यू विल बी हैविंग, दैट बिकम्स पॉजिटिव. That is also our limitation. Agar once your gram stain is negative, you will be assuming that there is no infection. There could be some other reason for the infection or for the sign and symptoms. Okay. But later, once the culture result will be there, it will show positive. So if your bacterial load is low, then gram stain will be negative, right? So it won't give you any effect. That is the second limitation. Third limitation is prior antibiotic exposure. So if the patient is having prior antibiotic exposure, just हर चीज में होता है, हर केस में होता है, that affects the result of the gram stain. If the patient has already, received antibiotics, so bacteria may be dead or, in the phase of disordered, so gram stain result that may be again misleading. So you must be correlate clinically. Never ever, find treatment based on gram stain if it is not an emergency case. It is supportive tool, guys, but not a confirmatory. For the confirmation, we need culture results. We need culture results to confirm everything. Okay. So till this slide, we discuss about gram stain. Now let me ask you if you have any questions, doubt related to gram stain. Do you have, or is it is understandable? Are you able to understand this? Gram stain? Till this slide, gram stain is there. From the next slide, we will be discussing culture report. Is it making sense to you? Are you able to understand it? What about other people? Okay. What are the limitation? What are the strengths? Right? Strength is only one, that in an emergency situation, of course, you can rely on the gram stain report first. It is useful to choice broad spectrum antibiotic at a first choice, right? But still you need culture report. So let's understand now what exactly the culture report is. This culture report. Now, what is the purpose we will discuss first. So now we come to the most important part of the whole module, and that is culture report. Culture report tells us, is there bacteria growth or not? Confirm the causative organism. Which organism is present, whether it is E. coli, Staphylococcus, what exactly it is, and which antibiotics will be further effective in this particular situation. So it will give you a clear idea. Culture report will show you the confirmation of the causative organism. It is providing identification so that you can better targeted therapy you can implement. It gives you a susceptibility pattern as well. What, okay, I will give you the idea about susceptibility pattern. I hope now you are familiar with the word susceptibility. That means which antibiotic will be more suitable, okay, susceptible, sensitive to the particular organism, okay, and so that you can avoid the other antibiotics which are toxic to the patient maybe, right? So it gives you a susceptibility idea also, and this is gold standard for the diagnosis. Never forget, okay, this is the gold standard. Gram stain, of course, mandatory. Culture report is the gold standard. Now you have idea why it is gold standard, right? Because it confirms everything. It confirms the causative agent, it confirms the identification, it confirms the susceptibility pattern. So culture is considered gold standard. It confirms the infection as well, okay, and it identifies the exact organism. It guides you a targeted therapy. So as a pharmacist, this is the report, you can rely on for the stewardship decision, guys. Whatever stewardship decision you are taking, this is the report you will be rely on, okay. So let's have some of the types. Let's understand some of the types of culture sample. We will be seeing whole culture report analysis, how exactly it is being done. सबसे पहले क्या चीज होगा? You need to collect the sample. So we have a special team for it. Sample can be blood culture. Blood culture sample किसमें use होता है? So use, in cases of sepsis, bacteremia, and it must be taken before antibiotic blood, and it requires adequate volume as well of the blood, right? Then second sample can be urine, so that is used in the cases of urinary tract infection, of course, or some type of midstream, infection. And for this, midstream sample of the urine is important. Second can be sputum sample, okay, that is used in the case of pneumonia and respiratory condition, but of course quality of sputum matters. Then we have also pus and wound swab, which is used in the skin and soft tissue infections. They will be taking the sample of pus. And sample क्या हो सकता है? Again, CSF भी हो सकता है, which is a cerebrospinal fluid. That can be used in the cases of meningitis, for example, or it can be also emergency sample, guys. So each culture has different interpretation rules, okay. One rule does not fit all, but we will be more focused towards the blood and the urine for this module, okay, because it is quite common. But please understand that every culture has different interpretation, and it gives you a different idea. It is not all same, okay. So based on the situation, based on what is the situation diagnosis, the sample collection is further, they can take choice. Now, culture growth terminology, you need to understand, understanding culture growth terminology. So, when you see a culture report, now understand the sample collection is being done in the laboratory, whole process is done. Now you have report with you. So, how exactly you will be saying this culture growth terminology? So, when you see a report, you will see the terms. You will see the terms like this, the 5 bullet points. You will be seeing term like no growth in the report, right? Now I'm directly jumping to the report because I'm assuming that you have now idea about the laboratory process, microbiology workflow, right? Because in the very first slide we had discussion on it. So let me just give you idea how exactly the report is all about. So report में ये सारी चीजें हो सकती है. Culture growth terminologies. Before reading any report, before jumping into the on the report, you must know the terminologies. So it can have idea, it can the terminologies which can be mentioned on the report. Very first is the no growth. Now no growth has direct meaning. That means no bacteria is detected, or it could be true negative, okay, it could be true negative as well, or it could be due to some prior antibiotic drug induced b infection hote, but there is no bacterial role in it, so it can be no growth, okay. Second is scanty, moderate, and heavy growth. It is also a abbreviation that is written on the report. Scanty, moderate, heavy growth, that indicates the bacterial load, guys. How many, how much load, bacterial load in the sample is, the patient is having, and that load is decided further the dose of the drug, okay. So scanty, moderate, heavy growth, it is directly indicated the bacterial load. It is very important in the wound and the sputum sample, guys, let me tell you, okay. Wound for the skin and tissue infection, and the sputum in case of respiratory pneumonia cases. In that condition, this is very important, bacterial load, because it decide further the dose of your antimicrobials, okay. Then pure growth. Pure growth means only one organism is isolated. प्योर वन, ओके। सो एज दिस प्योर वन, ऐसे आप याद रख सकते हो। प्योर ग्रोथ का मतलब होता है ओनली वन ऑर्गेनिज्म इज आइसोलेटेड एंड दिस इज यूजुअली सिग्निफिकेंट, ओके। बहुत रेयर केसेस में प्योर ग्रोथ मेंशन होता है, बिकॉज समटाइम मल्टीपल ग्रोथ इज ऑल्सो ऑलवेज इन्वॉल्व। Many time multiple growth is involved. Sometime pure growth is there. Pure means only one organism is isolated, while mixed growth means more than one organism. As I earlier told you, that many conditions are like that, in which many multiple bacteria you will be finding in the laboratory report. क्या लिखा होगा? Mixed growth. Mixed growth का मतलब है more than one organism. Often indicates contamination. Okay, and also the report is having colony count. This is very very important. Colony count is written in the CFU by ml. The unit is, if you are noting it down guys, not written here, but I hope you are having notes with you and you are making it, okay. So write it down. Colony counts are always comes in the unit of CFU by ml. CFU means colony forming units. Colony forming units per milliliter ml. ठीक है. So it is very important in the cases of urine culture, colony count. Okay. So we need to understand that whether it is significant UTI, whether it is contamination type of UTI. So the range of this colony count gives you idea about what type of the UTI a person is having. For your understanding, I am saying, because I remember right now the range, uh, 10 raised to 5 CFU per ml. That is significant UTI. 10 raised to 5 अगर कॉलोनी फॉर्मिंग यूनिट्स पर मिलीलीटर अगर दिखता है तो वो होता है सिग्निफिकेंट यूटीआई। वाइल अगर 10 रेस टू 5 से कम दिखे, लेस देन 10 रेस टू 5 और 10 रेस टू 3 CFU by ml, that is contamination and not significant. सो यूरिनरी ट्रीटमेंट, यूरिनरी इन्फेक्शन का ट्रीटमेंट भी इसी हिसाब से डिसाइड होता है, ठीक है। कॉम्प्लिकेटेड यूटीआई एंड अनकॉम्प्लिकेटेड यूटीआई. So you need to connect the dots here, okay. So this is how colony count is appears, and it is always interpreted number with the symptoms. We need to correlate everything with the symptoms. Many times your report is not talking much, and it is not correlating with the symptoms a person is having. In that case, reassurance is required, retest is required, because error chances are very huge, okay. So this is very important. Now we need to understand the contaminant versus the true pathogens, because कल्चर ग्रोथ टर्मिनोलॉजीज के बाद एक ये चीज है जो बहुत ज्यादा इंपॉर्टेंट हो जाती है while reading the culture report. Contaminants versus the pathogens itself. Now as I earlier told you here, the colony count, colony forming count 10 raised to 5 अगर होगा तो वो significant UTI है. That means bacterial pathogens are involved. While if less than 10 raised to 3 है, that means it is a contamination and there is no role of bacteria in it, pathogens in it. So you need to understand contaminants क्या होता है और pathogen क्या होता है, ठीक है. So not every organism grown in the culture is causing the disease guys. Not every, I am again repeating, not every organism which is grown in the culture is causing the disease. You need to understand contaminants that introduced during the sample collection. सैंपल कलेक्शन के टाइम पे इंट्रोड्यूस होता है. दिस इज नॉट कॉजिंग डिजीज. इट इज नॉट एग्जैक्ट कॉज ऑफ द डिजीज. इट इज नॉट ई कोलाई स्टेफाइलोकोकस, राइट. सो इट कैन बी स्किन फ्लोरा, okay, normal skin flora usually, and it is because of the improper collection, the error in the sample collection. Usually it is low virulence in the case, and it is ignorable, you can consider, but it is a contaminants through. So throughout the process, if something in the contaminant happens, that is what the contaminants means. And true pathogen, that means it causes the active infection, consistent with the symptoms, grows in the multiple samples, and significant, it is colony count. Significant in colony count. As I earlier told you, colony forming count, if it is 10 raised to 5, then it is what? This. 10 raised to 5, it is showing you a significant UTI. While if colony forming count is less than 10 raised to 3, it can be considered as a contaminant UTI. So you can understand now contaminants क्या होता है and the true pathogens क्या होता है. So for an example, I can give you example to understand this slide. For an example, a person is having fever, okay, plus blood culture growing E. coli. So अगर बुखार भी आ रहा है और E. coli कल्चर ग्रोथ में दिख रहा है, that means it is the true pathogen. But if there will be no fever plus single blood culture growing, you will be having a colony forming count, then it is the reason behind contaminant, right? So even if report is showing you something is happening, but the symptom is not there, patient symptom is not there, you can consider it a contaminant sign. So this is what relation with the symptoms look like. You need to read the report, you need to correlate it with the symptom and the clinical picture. Opposite scenario bhi ho sakta hai. If there will be symptom will be there and your report is showing no pathogen, right? So you need to always correlate. Okay, this distinction prevents unnecessary antibiotic use, guys. If you have idea about contaminants and pathogens, true pathogens and contaminants, you can prevent unnecessary use of antibiotics, because doctors, physicians don't have that much amount of time. If they see culture report and if they are seeing positive, they are even not, considering the symptoms and all, and they are prescribing large amount of antibiotics. Okay, and in fact, broad spectrum sometimes. So, of course, there is where exactly the clinical pharmacist can stand. They can monitor further, they can monitor exact effectiveness of the therapy, need of the therapy. And if you will work on it, you will find out of 100, 90, 80, 90% patient is actually not at need of the antibiotics and still they are taking it. और यही रीजन है कि हम स्टुवर्डशिप पे काम कर रहे हैं, यही रीजन है कि हॉस्पिटल्स आर कमिंग विद द एएमएस कमिटीज, एंटी माइक्रोबियल स्टुवर्डशिप कमिटीज. They are taking pharmacists in the committees, clinical pharmacists in the committees, so that your role is very wide in the AMS. Your role is this: you need to interpret the report, you need to understand the report in detail, you need to understand contaminant, pathogens, whether the patient is at exactly the need of antibiotic or not. Okay, and trust me guys, when I say this, every abroad category of clinical pharmacists are doing it. In India it is not happening at a low level, right? So we must understand our roles and responsibilities so that we can work in that direction. Okay, so I hope now it is clear: contaminant and the true pathogens. These are some of the examples I have included for your understanding. Common contaminants examples. See, this common contaminants includes the very first, that is CONS. CONS, that full form is written here: coagulase negative staphylococci. Now it is itself a negative. It looks like the staphylococcus, but it is a contaminant. Okay, it is because of some sample collection, unhygienic practice and all. जिसकी वजह से आ गया है, so that is known as a CON. रिपोर्ट में कैसे लिखा होता है? CONS. CO means coagulase का CO, negative N and staphylococci का S. ठीक है, so CONS means coagulase negative staphylococci. Also we have diphtheroids. Diphtheroids is also a contaminant. We have micrococcus contaminants. We have bacillus sepsis, sorry, species. बैसिलस के बहुत सारे ऐसे स्पीसीज है जो कि कंसिडर होते हैं एज अ नॉन एंथ्रेसिस, मींस दे आर नॉट कॉजिंग द डिजीज इटसेल्फ. ओके, सो these are some of the examples to understand these contaminants. Okay, and these organisms are normally, live. It is live on the skin, it is live in environment as well. That is the reason while in sample collection and handling of sample, ये जो है contaminants अंदर आ जाता है. ठीक है, and if they grow in only one sample, they can grow, and it is not giving you any clinical signs and symptoms, so they are usually known as contaminants. Many people are aware of pathogens, but many students are blank when they are facing the questions related to what are the examples of contaminants, right? So you must be aware of diphtheroids, micrococcus, bacillus species, some, and CONS, coagulase negative staphylococci. These all are considered as contaminants. If this is written in the report, you can ignore it. That is what you need to understand. And when the contaminants matters, कब ये चीज मैटर करती है? So now come to a tricky part. Sometimes contaminants become real pathogens. Okay, now this is the very catchy thing, and you need to understand some, because it is also a bacteria in nature, right? They can turn into the pathogen, guys. Okay, sometimes contaminants, very rare cases, becomes the real pathogen. और ये किन चीज कंडीशन के पेशेंट में होगा? ऑफ कोर्स इसका इम्यून सिस्टम कंप्रोमाइज्ड है, ठीक है। सो इट इज जनरली हैपेंस इन द इम्यून कंप्रोमाइज्ड पेशेंट, ओके, इन dwelling devices if used by the healthcare professional, repeated isolation from the same site, अगर ये चीज हो रही है तो उसमें भी होगा। clinical deterioration is the outcome. Okay, so it is very common in the ICU patient, immune compromised patient, patient with, central lines, prosthetic valves, and the implants. In patient with this condition also, this contaminants can become the real pathogen. Okay, so for an example, I can give you idea like repeated blood culture अगर हो रहा है, repeated blood culture test हो रहा है, for example, in an ICU patient, which is mandatory, okay, daily basis. So repeated blood culture growing further the CONS in the patient with the catheter. Okay, so this is not contaminants. This is catheter related bloodstream infection further. Okay, central line bloodstream infection हो सकता है, catheter related bloodstream infection हो सकता है, and this is because of this CONS, right? This coagulase negative staphylococci, which is present on the skin. So this is how the sometimes contaminants can also become the pathogens sometime. So always correlate your lab, patient's own condition, and repeated cultures. Okay, you need to be aware of repeated culture. I hope this fundamental thing is clear to you. Culture report. Is it clear? Is it clear? Yes, okay. I will let I think you I have some questions. Is it possible I will give you answer at the end because this is the flow we need to, make sure. Okay? Yes, repeated exposure from the same site. Repeated exposure, repeated isolation. Isolation means collection. Okay, so from the same site. So that is also the reason behind it. Okay, so let's continue with the another term which is very important in case of antimicrobial susceptibility test, which is MIC. So MIC का introduction मैंने आपको introductory slide में ही दे दिया था, which is minimum inhibitory concentration. Minimum inhibitory concentration, the lowest concentration of an antibiotic that is preventing visible growth of the bacteria in lab. Okay, in lab, in vitro we can say, MIC की definition में ये बहुत important word है. So lowest concentration of an antibiotic inhibiting the visible growth of the bacteria in vitro means in lab. Okay, so the unit is here written, it is microgram per milliliter. The unit is microgram per milliliter. It is a quantitative measure, of course it will give you the quantity. Okay, so interpretation is very clear. If the low MIC is there, more potent antibiotic will be required. If the higher MIC is there, less effective antibiotic will be required. So I will give you idea. If you are not understanding it, don't worry. We will be having 5 6 slides on the MIC to understand the concept. Gram stain is clear, culture report is clear. Now we are at the MIC. Okay, so for an example, it is helping us to compare the antibiotic potency, of course. So I will give you the example. Just understand, drug A is there and drug B is there. Drug A का जो है minimum inhibitory concentration 0.25 microgram per ml है और drug B का 4 microgram per ml है. Again, I am repeating, drug A is having 0.25 MIC, minimum inhibitory concentration 0.25, and drug B is having a 4 microgram per ml as a minimum inhibitory concentration. Which drug will be more potent? You will consider. जिसका कम डोज ज्यादा माइक्रोब्स को किल कर सकता है या फिर जिसका डोज ज्यादा हो वो किल कर सकता है, कौन सी दवाई आप पोटेंट कंसिडर करोगे? एग्जैक्टली exactly. Exactly. Yes, जिसका dose कम है. If the drug is having low, right? Lower MIC, that means it is a more potent antibiotic. And higher MIC means less effective antibiotic. Whether it is clear to you? Low dose, yes, drug A. Right, right. I am happy by your answer. Yes, so this is very important MCQ, in competitive exams they are asking. that lower dose is more potent antibiotic, higher dose is less effective antibiotic. So drug A will be more potent. And that is what the fourth bullet point. It is help to compare antibiotic potency, right? We are here to comparing the antibiotic potency. So MIC is responsible to compare the potency of the antibiotic. If the drug is having low MIC, it will be more potent. If the drug is having high MIC, it will be less effective, right? So let's understand MIC versus susceptibility. MIC versus susceptibility concept. So student often think like low MIC means sensitive. Agar low MIC है, that means we required a drug's minimum inhibitory concentration which is low, तो वो ज्यादा susceptible है. Okay, but this is wrong. This is wrong unless you compare it with the break point. What do you mean by break point? This is a very big concept in the antimicrobial stewardships, right? Break point means this S, I, and R: susceptible, intermediate, and resistant. Okay, so break point means susceptibility category. We need to understand कि susceptible भी अगर है तो कितना है. There is a category of susceptibility. It is 100% susceptible, it is S. If it is intermediate itself, the meaning intermediate means may or may not be, and resistance means complete no. So the same MIC value, same MIC value of a drug that may be sensitive for one and resistance for another. ओके, सो सेम MIC वैल्यू अगर बोला जाए कि पैरासिटामोल हैज मिनिमम इनिबिटरी कंसंट्रेशन 500 mg is required to kill a particular bacterial growth. So this can be sensitive for one condition, and the same MIC can be resistant to some another condition, right? So this is very important. MIC must always be interpreted with susceptibility break point. ओके, सो मिनिमम इनिबिटरी कंसंट्रेशन एक बार आपको पता चल गया कि हाँ ओके, एसिटामिनोफेन का 500 mg इज रिक्वायर्ड इन द नॉर्मल अडल्ट टू किल द बैक्टीरियल ग्रोथ. इट कैन एक्सटेंड अप टू 650 mg, ओके, ट्वाइस अ डे एज वेल. ये आपको एक बार पता चल गया कि MIC ये रेंज है, बट इफ यू आर नॉट कंपेयरिंग इट विद ससेप्टिबिलिटी पैटर्न, वेदर इट इज ससेप्टिबल, इंटरमीडिएट, रेजिस्टेंट इन अ पर्टिकुलर केस, it is again has no meaning. Okay, so MIC must always be interpreted with the break point. Break point means susceptible, intermediate, and resistant. Okay, here there is a understanding of break point. See, break point कौन decide करता है? So we have two different bodies. We have CLSI, Clinical and Laboratory Standard Institute. If you are noting it down, full forms, note it down. Clinical and Laboratory Standards or Standard Institute. In India, CLSI is being used. In US as well, CLSI is being used. And the EUCAST is the European Committee on Antimicrobial Susceptibility Testing. Obviously, in the Europe region, EUCAST is used. Let me give you idea to you. EUCAST का जो गाइडलाइन है ना, वो ज्यादा स्ट्रिक्ट है गाइस. ओके, वो ज्यादा स्ट्रिक्ट है ब्रेक पॉइंट्स के बारे में. many drugs are sensitive, many drugs are sensitive as per CLSI guidelines, while many drugs are written as resistant as per the EUCAST guidelines. EUCAST is more stricter guidelines, but in India we have CLSI. Okay, so these breakpoints, which can be susceptible, which can be resistant, which can be intermediate, these guidelines are set by these two independent body. These two are international bodies working on this. Okay, and how they are deciding this? They are deciding based on the pharmacokinetic drug levels in the body, pharmacodynamics, drug effect on the bacteria, clinical outcomes, and the resistance mechanism. They are monitoring those parameters, and then they are deciding the breakpoints. So as a pharmacist, understanding this breakpoint further help us to choose the better dose. Okay, better dose of the antibiotic, antimicrobial, choosing the correct antibiotic as well. Okay, अगर susceptible आया तो you will go okay with it. Sometime resistant आया तो you won't go with it. And बहुत सारी दवाई जो है दोनों susceptible भी आ सकती है. So you will be the one who will be deciding which antibiotic you need to go with. Right, so break point समझना बहुत जरूरी हो जाता है. So you will be doing a dose optimization, choosing the correct antibiotic, and avoiding any type of treatment failure later. That is what the break point is. Okay, now how pharmacists use MIC? कैसे use करते हैं? So now that you understand MIC and break point, so that is the correct time to discuss about how pharmacists actually use MIC in practice. Okay, we do not use minimum inhibitory concentration just to label the drug, guys, as sensitive or resistant. Okay, we are not doing it for. We are using, pharmacists are using MIC for choosing between two susceptible antibiotics. Very important. यू आर कंपेयरिंग टू ससेप्टेबल एजेंट्स. सोचो अगर एक केस ऐसा हुआ कि जिसमें एंटीबायोग्राम इज सजेस्ट, सॉरी, एएसटी रिपोर्ट इज सजेस्टिंग यू, ससेप्टेबिलिटी टेस्टिंग रिपोर्ट इज सजेस्टिंग यू टू antibiotics which is susceptible to kill the bacteria. What you will be choosing? It is very easy if it is only S, I, and R. But what happens if you have multiple options? So here your pharmacological, toxicological, therapeutical whole knowledge of your, curriculum will be come together. And then you will be comparing which antibiotic will be useful for the patient. And that is exactly the role and responsibility a clinical pharmacist is having. In fact, a normal pharmacist is having. Okay, when we are, always blame the, I don't know whether the government, whether these and that, for the less opportunity, less pay and all, but we are somewhere missing in this thing, guys. We are not doing it in practice. Our students are also not doing this practice, and this is what exactly the hospital are asking for, so that you can actually decrease the resistance load, you can actually decrease the healthcare, cost, by choosing the more susceptible agents. So MIC का यूज क्या है? MIC का यूज ये नहीं है कि हम सिर्फ देख के लेबल लगा दें कि ये ससेप्टेबल है, ये रेजिस्टेंस है. नो, MIC का मतलब है you are choosing between two susceptible antibiotic. For example, let me give you example. If you have a combination with you, piperacillin tazobactam, very common example. उसका अगर मिनिमम इनहिबिटरी कंसंट्रेशन आ रहा है 8 माइक्रोग्राम पर ml, that is that is suggesting you a sensitive, that yes, in this particular situation piperacillin tazobactam you can go with. Same, second, meropenem drug. Meropenem is giving you a 0.25 microgram per ml, and also it is giving you an idea that is it is also sensitive. Both are S, but meropenem is more potent because the less drug dose is required to kill the bacteria, while piperacillin tazobactam is suggesting you 8. That means more dose is required. So it is a reserve drug, right? Meropenem is more potent and it is a reserve drug. So we may choose piperacillin tazobactam if the patient is stable. And if the patient is not stable, we will choose the meropenem, that is a carbapenem actually, right? Both are sensitive, both are effective in the treatment. You are a pharmacist, you have idea about MIC is written in the report. Piperacillin tazobactam 8 microgram चाहिए होगा to kill the bacteria, and meropenem जो है हमें 0.25 microgram चाहिए होगा to kill the bacteria. Now you know कि अगर less dose required है तो वो potent option है. ठीक है, potent option है. Meropenem is a potent option for this particular condition. So you will be directly going to the meropenem? No, because it is a last resort drug. You need to reserve that drug, right? If the patient is stable, you will be choosing the combination. भले ही वो 8 माइक्रोग्राम पर ml का है, ठीक है? And if the patient is in unstable condition, you will be choosing the other option. This is what the comparing two susceptible agent is look like. Okay, so depend on the clinical scenario. Pharmacist duty is to choose comparing the two susceptible agents. So very, very important. So we may choose the piperacillin if the patient is stable and to preserve the carbapenem. And you can, imagine the opposite scenario as well. Right. Second duty, why pharmacists use it? I hope third bullet point is clear, comparing two susceptible agents. Now, how pharmacists use MIC? Dose optimization. Higher MIC, higher dose, or prolonged infusion is required. So you will choose dose appropriately. What exactly the patient is, fit into it. Of course. Third is in a severe, in severe infection, like in sepsis, meningitis, endocarditis, you are preferring antibiotic with low MICs because patient is not stable, right? So this is where PharmD expertise matters. This is where pharmacist matters. In a dose optimization, drug selection in severe infection में आप क्या करोगे? MIC जिसका कम है वो drug select करोगे, ठीक है? Because that will be more potent and patient's condition is not stable. Of course, you will go with it. But if the patient is stable, you will be choosing MIC higher value. You will be reserving the last resort agent for this particular patient if he or she is in stable condition. This is how comparison of two susceptible agent is, happen. And guiding de-escalation. I hope you have idea about de-escalation to narrow down. Okay, पहले broad spectrum से start करना, उसके बाद once you have culture report with you, now you are having idea that which organism is this, and which antibiotic will be needed. You will be narrow it down further. Targeted therapy पे जाओगे, and that is the concept of de-escalation. Okay, so this is very important. Susceptibility pattern we need to understand. But first, I need to confirm. Is it clear? This slide is clear to you? Is this slide clear to you? Making sense? I hope you are understanding it because बहुत जरूरी है ये चीजें, ठीक है? I need to I need to you know I need to convey the message that this is the roles the PharmD and pharmacist are having. अगर ये चीज हमने कर ली एक बार, we can ask for the better pay, guys, and no one will deny, right? But the sad reality is in our curriculum, these things are not there. Okay, even if your professors wants to discuss, they are not having enough time because of the lengthy syllabus completion and all. And when I said you need to compare two susceptible agent, guys, it also requires pharmacology, therapeutic, toxicology, microbiology all together. Okay, so base should be strong. Base should be strong. So whatever you are learning in your institution is also very important to set the base, and that is the reason behind certification courses. ठीक है? So this is very important when you understanding something beyond classroom. Okay, so let's start with the susceptibility pattern now. You need to understand antimicrobial susceptibility pattern. Okay, this pattern shows us how bacteria are behaving over the time. ये कैसे behave होता है, ठीक है? This is helping us to detect the emerging resistance. This is also helping us to monitor the antibiotic misuse, guys. Okay, and this is also helping us to identify the problematic organism in the ICU as well. Okay, so pattern is showing you the resistance trends. Okay, trend means pattern. Okay, so it is showing you the resistance pattern in your geographical area. And इसी susceptibility pattern से ही antibiogram बनता है. Antibiogram means your own hospital, your own clinical setting is having one report kind of thing, which gives you idea कि आपके environment में कौन कौन से organism है जो resistance develop कर रहे हैं, so that you can choose a better therapy. Okay, so susceptibility pattern is showing you the resistance trends pattern over the time. It is detecting the multi-drug resistance organisms. Okay, we are having lots of organisms in the healthcare which are now MDR. Okay, we have three different term, guys: MDR, XDR, and PANDR. Okay, PDR. So PANDR actually. So MDR means multi-drug resistance. Name itself has meaning. Many drugs will be resistance. Okay, bacteria are evolving themselves. Beta lactamase बना रहे हैं, carbapenemase बना रहे हैं. The enzyme which is made in their body, which is further resistance develop कर रहे हैं against our very powerful beta lactams and all. Also, we have some of the very big concepts. Third generation cephalosporin is also resistance in some cases, right? So MDR is multi-drug resistance. Okay, XDR एक condition होती है which is extensively drug resistance. What do you mean by extensively drug resistance? You will be having very less option. Extensively means MDR में तो भी थोड़े बहुत option बचते हैं antibiotics के. XDR condition में you will be having only a last resort drugs like colistin, linezolid. These options only you will be having. एंड पैन ड्रग इन्फेक्शन जो होता है, पैन ड्रग रेजिस्टेंस जो होता है, उसमें लिनेजोलिड एंड कोलिस्टिन का भी रेजिस्टेंस डेवलप हो जाता है. So you will be having no option in the pan drug. Okay, so there will be no option in the pan drug resistance. Okay, so there is three different MDR, XDR, and PDR. I will be having next slide on to this only, so you will be having clear idea. But yes, susceptibility pattern give you the idea about MDR. It is guiding a stewardship decision, and it is help us to avoid ineffective therapy. Of course, if you are identifying it correctly, ineffective therapy you can eliminate. Okay, so this is the pattern you it is helping to understand. This is I was talking about MDR, XDR, and PDR. So these are the terms you must clearly understand and remember because this is written in the report, guys. Okay. MDR is a multi-drug resistant. That means resistant to at least one agent in the three or more antimicrobial classes. Okay. जो भी यहाँ पे लिखा हुआ है मैंने उसको वर्ड फॉर्म में बोला ताकि आपको ज्यादा समझ आए. MDR means it is resistant to at least one agent. Okay. One agent in the three or more antimicrobial classes, greater than or equal to one agent in greater than or equal to three classes, right? So this is MDR. In XDR, consider that is extensively drug resistant. The full form is extensively drug resistant. It will be susceptible to only one or two classes. As I said, XDR की treatment में सिर्फ colistin और linezolid option बचते हैं, last resort drugs. Okay, and we have PDR. PDR is a pan drug resistance, pan drug resistant. That means it is resistant to all the available, classes of antibiotic, resistant to all the classes. Okay, so for example, मैं आपको example देती हूँ for your understanding. MDR के लिए example है E. coli. E. coli is, still treatable. E. coli is responsible for multi-drug resistance, guys. एंड इट इज स्टिल ट्रीटेबल. ठीक है. XDR के लिए हमारे पास एग्जाम्पल है एसिनोबैक्टर. एसिनोबैक्टर इज the moiety which is responsible for extensive drug resistance. So we will be having a very limited options like linezolid, colistin and all last resort drugs. And pan drug के लिए जो organism responsible है, these are at most untreatable you can consider, and that can be any. That can be any. Okay, and these infections are very common. MDR, XDR, PDR is very common in ICU, long hospital stays and ventilated patient. Okay, और यहाँ पे बहुत ज्यादा common MDR, XDR है. And this is very this is a threat actually. Okay, in the healthcare. MDR, XDR, PDR is a threat in the healthcare. We must intervene and we must solve. Last topic for the discussion, antibiogram. Now, as I earlier told you, it is a report of susceptibility thing. Okay. Now you know the word susceptibility. It is a cumulative susceptibility report. But what to understand? It is a unit specific or hospital specific. मैंने आपको बताया पहले कि आप जहाँ पे काम कर रहे हो वहां की हॉस्पिटल या आपके जो क्लिनिकल सेटिंग के सराउंडिंग्स में जियोग्राफिकल एरिया में कौन सा रेजिस्टेंस पैटर्न बढ़ रहा है, दैट रिपोर्ट इज एंटीबायोग्राम. तो ये एक हॉस्पिटल का दूसरे हॉस्पिटल के साथ कंपेयर नहीं हो सकता. ठीक है. और ये एक गोल्ड स्टैंडर्ड जैसा भी नहीं हो सकता. ठीक है. इट विल बी डिफरेंट. So it is usually updated annually by looking at what patterns we are identifying in our clinical setting. And this is very essential for the broad spectrum therapy, guys, empirical therapy. Why? Because if I know that my hospital has E. coli, resistance, so I will be choosing some broad spectrum which is not targeting those molecules, right? So this is how the antibiogram is helping. It is a summary report, guys. I can say it is a cumulative report of all antimicrobial susceptibility of, organisms which are isolated in the hospital over a specific period of time. Over a specific period means it is usually updated annually. 1 year ka hi hota hai. And this antibiogram tells us which antibiotic work best in our hospital and which antibiotic have high resistance in our hospital setting. So it is location specific, like ICU antibiogram अलग होता है, ward antibiogram अलग होता है, hospital का खुद का एक antibiogram होता है. ठीक है. So these are the things. If you are working in the hospital right now or going in the ward round, right, ask where is our hospital antibiogram. Try to interpret it. Okay, let me give you idea how to read antibiogram. I hope now it is clear what is actually the antibiogram, how to read it. So let us understand how to read it. For example, this report has organism listed vertically. Okay, so every organism will be there vertically and antibiotic will be listed horizontally. Okay, and it will also give you a percentage of susceptibility. It will be showing that organism is imagine एक साइड पे कॉलम्स में ऑर्गेनिजम्स लिखे हुए हैं एंड एंटीबायोटिक रो में लिखा हुआ है जस्ट लाइक एन एक्सेल शीट. ओके, और ऑर्गेनिज्म में लिखा हुआ है ई कोलाई और एंटीबायोटिक के नीचे लिखा हुआ है एमिकासिन. ओके, और उसमें परसेंटेज दिया होगा फॉर एग्जांपल 85%. दिस मींस out of 100 E. coli isolates, 85 were sensitive to amikacin. 85% केसेस ऑफ ई कोलाई में आप अगर एमिकासिन ट्रीटमेंट दोगे तो वो वर्क करेगा. सेंसिटिविटी मीन्स इट विल बी, yes, you can go with it. But 85% that shows that, imicacin empirical choice है, ठीक है, broad spectrum antibiotic choice है. So how much percentage of reliability will be there? कितना परसेंटेज मैं उसके ऊपर ट्रस्ट कर सकता हूँ, ये आपको एंटीबायोग्राम दिखाता है. ठीक है, आई होप इट इज क्लियर टू यू. Imagine organism is listed in a column, antibiotic in a row, just like an Excel sheet. Imagine करो organism में E. coli लिखा हुआ है और एंटीबायोटिक में इमिकासिन लिखा हुआ है और उसके नीचे परसेंटेज लिखा हुआ आता है, फॉर एन एग्जांपल 85%. दैट मींस आउट ऑफ 100 E. coli isolates, 85 are sensitive to imicacin. So higher the percentage, better the empirical choice. Okay, so important rule here is avoid, I will say again, avoid empirical drugs with less than 70% susceptibility. अगर नेक्स्ट टाइम आपने एंटीबायोग्राम हाथ में लिया और आपको दिखा कि ई कोलाई है और एमिकासन ट्रीटमेंट लिखा हुआ है बट वो ओनली 65% दिखा रहा है, तो आप क्या करोगे? यू विल नॉट चूज एमिकासिन फॉर दोज ई कोलाई पेशेंट. आर यू एबल टू अंडरस्टैंड एंटीबायोग्राम नाउ? Yes or no? Are you able to understand antibiogram? What about other people? Repeat once more. Okay, we can. See, reading an antibiogram means organisms are written here and the antibiotics and the percentage. Okay, how exactly it is written? Just have you seen Excel sheet? Excel sheet कभी देखा है? एक साइड पे कॉलम्स होते हैं, ऊपर एक लंबी रो है, ठीक है. तो कॉलम्स में ऑर्गेनिजम्स लिखे होते हैं, रो में होता है एंटीबायोटिक्स. फॉर एन एग्जाम्पल, फॉर योर अंडरस्टैंडिंग, आई एम सेइंग, इमेजिन कि ऑर्गेनिज्म में पहला लिखा हुआ है ई कोलाई, दे आर मेंशनिंग ई कोलाई इन द ऑर्गेनिज्म एंड एंटीबायोटिक इज रिटन फॉर एन एग्जांपल एमिकासिन. एंड वहां पे जहां पे वो दोनों कनेक्ट हो रहे हैं, वो जो सेल है वहां पे परसेंटेज लिखा हुआ होता है, दैट फॉर एन एग्जांपल 85%. सो दैट मींस 85% you can rely on this treatment for the E. coli. एमिकासिन आप 85% ट्रस्ट कर सकते हो for E. coli cases. So out of 100 E. coli isolates, 85 were sensitive to amikacin. That is what antibiogram is all about. ऐसे एक नहीं, ऐसे 100 लिखे हुए होते हैं guys. ठीक है, बहुत सारे ऑर्गेनिज्म का लिस्ट होगा इन द कॉलम, बहुत सारी एंटीबायोटिक का लिस्ट होगा इन अ रो, and lots of percentage are there. But by reading an antibiogram, you can at least understand how much percentage I can rely on the treatment. राइट, हायर, जितना हायर परसेंटेज होगा उतना बेटर चॉइस होगा, ठीक है, बेटर एम्पेरिकल चॉइस होगा. एंटीबायोग्राम इज हेल्पिंग अस टू चूज द ब्रॉड स्पेक्ट्रम एंटीबायोटिक्स. बट एक चीज ये है कि ऑलवेज अवॉइड दिस एम्पेरिकल ड्रग्स विथ लेस देन 70% ससेप्टिबिलिटी मेंशन इन द एंटीबायोग्राम. अभी इमेजिन करो कि ई कोलाई लिखा हुआ है और एमिकासिन लिखा हुआ है और 65% पॉसिबिलिटी दिखा रहा है, सो यू वॉन्ट गो विथ इट. दैट इज वॉट आई एम टॉकिंग अबाउट. आई होप नाउ इट इज क्लियर. इज इट? पैन ड्रग इन्फेक्शन के लिए क्या ट्रीटमेंट होगा मैं आपको बाद में बताती हूँ. अभी के लिए प्लीज फोकस ऑन द एंटीबायोग्राम, वेदर इट इज क्लियर और नो. Yes, okay. I'm happy by your answers. It is very important to understand how to read because many students are not aware of itself antibiogram. They are not asking in the hospital कि ऐसा भी कुछ चीज होती है, ठीक है. So understand if there is nothing like कि आपको सब कुछ डीपीरो के एल्गोरिथम के हिसाब से ही ट्रीटमेंट जाना है. That is the base. But according to the resistance pattern in your geographical area, in your hospital setting, you need to correlate everything. And that is where exactly antibiogram is standing. It is, very useful. So, yes, this is how it is being readed. Empirical therapy using antimicrobial antibiogram, how to decide. So, empirical therapy means starting antibiotics before the culture report. First of all, understand what is empirical. Empirical means you are starting with the broad spectrum before you are having a culture report with you. Once the culture report will be there, you will be de-escalating. That means broad spectrum से आप फिर narrow spectrum में switch करोगे, targeted therapy पे switch करोगे, ठीक है. But empiric therapy means starting any antibiotic before the culture report. What is the pharmacist role? You will use antibiogram for it. You will choose narrowest effective agent and you will avoid unnecessary any type of carbapenem and all because those are the last resort agent, right? So choosing agent with the highest susceptibility, considering the site of infection and patient related factors, avoiding overuse of broad spectrum drugs, adjusting one culture report once the culture report is available. These all are the roles and responsibility a clinical pharmacist is having. Okay, so for an example, if the ceftriaxone susceptibility is 50% in the antibiogram, you will not choose it as an empirical choice, even if it is a broad spectrum. सेफ्ट्रियाक्सोन एक ब्रॉड स्पेक्ट्रम एंटीबायोटिक है, राइट? बट अगर आपका एंटीबायोग्राम हॉस्पिटल का उसका परसेंटेज 50% दिखा रहा है, यू वॉन्ट गो विथ इट. दिस इज हाउ यू विल एडजस्ट योर थेरेपी यूजिंग एंटीबायोग्राम. सो दिस कैन डेफिनेटली प्रिवेंट वॉट ट्रीटमेंट फेलियर रिस्क. क्योंकि एंटीबायोग्राम में अगर है तो वो एनुअली कुछ चीज असेसमेंट करके बनाई जाती है, ठीक है? दे आर सीइंग द रेजिस्टेंस पैटर्न एंड ऑल, right? So if you are choosing a ceftriaxone, even if with the 50% resistance will be there. This is what the importance of antibiogram. We have some cases for the discussion. Just understand this case and then we will be switching to the question and answer. This is the case of uncomplicated UTI, guys. Young female patient with the dysuria and the frequency, burning maturation and frequency. Urine culture identify the E. coli. See this CFU. I already told you what is CFU, colony forming units. It's showing a greater than 10 raised to 5. That means it will be नॉट अ कंटामिनेंट केस. यूटीआई के केस में ये बहुत ज्यादा इंपॉर्टेंट हो जाता है टू चेक करना कि ये कंटामिनेंट तो नहीं है, ठीक है? बिकॉज ऑफ पुअर हाइजीन ऑफ द हॉस्पिटल. यूटीआई इज वेरी कॉमन हॉस्पिटल एक्वायर्ड इन्फेक्शन, राइट? सो सीएफयू से आपको पता चल जाएगा वेदर इट कंटामिनेंट और ट्रू पैथोजन, ऑफ कोर्स. ओके, सो इफ द ई कोलाई इज देयर 10 raised to 5 से ज्यादा अगर colony forming unit है, that means it is not contaminant case. And your antibiogram is suggesting it is sensitive to nitrofurantoin and phosphomycin, but resistant to the fluoroquinolones. So what you will choose here? Obviously, you will go with what sensitive report is suggesting. Okay, so nothing to guess here, just to understand the flow. That yes, if the patient is having this, I hope now you are able to correlate this case. Anything in this case new to you now, after understanding the whole concept? I don't want to ask and guess the diagnosis and all. I don't want that. Are you able to understand this case? Connect kar pa rahe ho? Are you able to connect the dots? Yes or no? Yes, that is what I want. So if you are able to connect the dots, particularly in this case, the whole lecture is making sense. आपने पूरा लेक्चर सुना है, ठीक है? तभी ये चीज आप कोरिलेट कर पाओगे, बिकॉज एवरी बुलेट पॉइंट इज समथिंग विच वी ऑलरेडी डिस्कस्ड. ओके, सो व्हाट विल बी द कल्चर रिपोर्ट? कल्चर रिपोर्ट में बैक्टीरिया का नाम आ जाएगा, ठीक है? विच ग्राम स्टेन में ये चीज नहीं आएगी. ग्राम स्टेन में क्या आएगा? ओनली द ग्राम पॉजिटिव एंड नेगेटिव. यहाँ ग्राम स्टेन रिपोर्ट विल शो ग्राम नेगेटिव बैक्टीरिया इज देयर. Culture report will show E. coli is there. Culture report will show what is the colony forming unit range. So it will again give you the idea whether it is contaminant or sensitive. Okay. And अगर वो चीज अगर कंफर्म है कि नहीं ये पैथोजन रिलेटेड ही है, तो फिर आप जा सकते हो एंटी माइक्रोबियल सॉरी सेंसिटिविटी टेस्टिंग पे या फिर आपके एंटीबायोग्राम पे, और वो आपको दिखाएगा परसेंटेज. फॉर एन एग्जांपल, एएसटी रिपोर्ट विल शो यू वेदर इट इज सेंसिटिव टू nitrofurantoin, phosphomycin, fluoroquinolones, whether it is resistant to these things. Okay, AST will show you this, and your antibiogram will show you कि अगर आपको nitrofurantoin भी अगर यूज करना है, how much percentage of possibility will be there, reliability will be there to use nitrofurantoin in your hospital setting in the UTI. So every report is connected when you are deciding a therapy. Correct? समझ आ रहा है ये चीज? आर यू एबल टू अंडरस्टैंड? मैंने सारा कुछ जो है समराइज कर दिया है इसी केस में. ओके, सो दिस इज वेरी इंपॉर्टेंट. क्लिनिकल केस 1. सो रॉन्ग चॉइस यहाँ पे सिफ्रोफ्लोक्सासिन अगर आप जा रहे हो, दिस विल बी रॉन्ग. दिस इज अ रैशनल एंटीबायोटिक यूज. इफ यू आर कनेक्टिंग एवरी रिपोर्ट ऑल टुगेदर, डिसाइडिंग ट्रीटमेंट लेटर, it is the rational use of the drug, quality use of the medicine. Okay, so UTI interpretation point. See here, key point in UTI management, you will not, do not treat asymptomatic bacteremia. Symptoms should be there. Always check colony count. Colony count is very significant. Why? You already has answer. राइट, बिकॉज वो फॉल्स भी हो सकता है, ठीक है, वो कंटामिनेंट भी हो सकता है. सो कॉलोनी काउंट, कॉलोनी फॉर्मिंग काउंट विल टेल यू whether it is pathogen related or contaminant. So this is very important. Avoid treating asymptomatic, as I earlier told you. Prefer narrow spectrum oral agent. Okay. Avoid unnecessary IV antibiotics, I will say. And short course therapy is sufficient अगर है तो वही choose करना चाहिए. So pharmacist must actively, prevent the over treatment, guys. Okay, in the UTI cases. Second case is bloodstream infection. See here. Case is ICU patient, fever and hypotension is there. Fever, hypotension in the ICU patient. Blood culture is showing a gram positive. Sorry, the positive word is not written here, but gram positive is the blood culture report, and bacilli is the organism which is identified. Bacilli can be this identified as Klebsiella pneumoniae and ESBL producer. What do you mean by ESBL? ESBL is extended spectrum beta lactamase. Now, when I say ACE, lactamase, that means it is an enzyme. Okay. Now, when I say producer, that means this Klebsiella pneumoniae has capacity to produce one enzyme which is extended spectrum beta lactamase, which is highly making themselves resistance to all type of beta lactam. And when I say this, third generation cephalosporin bhi isme kaam nahi karta when it is a case of ESBL. That is the reason why it is extended spectrum. उसका spectrum बहुत बढ़ चुका है beta lactamase का. ठीक है. Now this beta lactamase is enzyme which is produced by the bacteria just for the resistance to the beta lactam, are very important antimicrobials. Right? So ESBL producer Klebsiella pneumoniae. That is very important word. You need to understand. Meaning it will be resistance to penicillin and cephalosporin. Okay, so this is one of the another thing to discuss जो कि theory में नहीं आया है, but you need to understand कि अगर ESBL producer लिखा हुआ है, that meanings beta lactam से resistance होगा. You cannot use penicillin and you cannot use cephalosporin. Third generation cephalosporin still will be resistant. Okay, so treatment of choice will be different in this case. So what will be the treatment? See this BSI interpretation. So you need to understand how will be you are doing the interpretation. ESBL, that means cephalosporin you will avoid. As I earlier told you, penicillin and cephalosporin third generation भी काम नहीं करेगा. So you will completely avoid cephalosporin in case of ESBL. यहाँ पे क्या preferred होगा? See, carbapenem preferred initially. Okay, so carbapenem will be the preferred choice. Dose optimization, of course, it is important. Further, you can de-escalate after some time if possible. So ESBL infection agar aaya, so that cephalosporin will fail. Carbapenem will be the drug of choice. Pharmacists are there responsible for ensuring the correct carbapenem selection. Which carbapenem drug you will select? Dose adjustment according to renal function test, whatever we have understood yesterday, according to liver function test, what day before yesterday we understood. We need to correlate and understand the dose. We need to monitor the response and further de-escalate whenever it is possible. So early, appropriate therapy saves lives. That is what we can do here. I hope it is clear. ESBL case, extended spectrum beta lactamase. Then third case we have as an MDR. See here, the ventilated patient with the pneumonia is there. The culture is showing Acinetobacter baumannii. It is resistant to most of the antibiotics. You must know. Acinetobacter, right? Acinetobacter is the MDR responsible. I told you in the slide of MDR, the example, Acinetobacter. And it is resistant to most antibiotic and sensitive to only colistin. I told you MDR or XDR में सिर्फ आपके पास थोड़े बहुत ऑप्शन रह जाते हैं, and one of the option is the colistin. Last resort drug consider करा जाता है इसको. Colistin is last resort antibiotic. नेफ्रोटॉक्सिक और न्यूरोटॉक्सिक ड्रग है ये, बहुत ज्यादा लार्ज साइड इफेक्ट प्रोफाइल है उसकी, neurotoxic and nephrotoxic. That is the reason why it is in the last resort category. So it requires a TDM as well and careful monitoring as well. Okay, so MDR का केस कुछ ऐसा दिखता है. ठीक है, that is the reason behind putting this case in front of you. How to manage this? How to manage MDR infection? So MDR management requires restricted antibiotic use, combination therapies, monitoring kidney function test, and strict infection control. Okay, stewardship oversight. So pharmacists are playing role in the managing MDR infections. So you can correlate all the things together and you can manage the MDR, right? Common interpretation errors people are doing. So, see, treating the contaminants as the infection. Now you know what is contaminants. Sometime contaminant भी pathogen में convert हो सकता है, but जब तक नहीं होता, उसको treat करना एक बहुत ही ज़्यादा misunderstanding, false symptoms and all सब कुछ उसमें आता है. So we need to understand what is the contaminant, how to identify it. Okay, coronary forming units you need to be aware of. Ignoring MIC trend, you must be knowing what is minimum inhibitory concentration pattern, right? ये क्या है पैटर्न? सम टाइम पहले साल में हो सकता है एमआईसी आपको थोड़ा कम दिखा रहा है. फॉर एग्जाम्पल एमिकासिन का ही लेते हैं. एमिकासिन एमआईसी इज शोइंग यू अ लेस इन फर्स्ट ईयर. सेकेंड ईयर का पैटर्न आपको दिखाता है कि एमिकासिन का एमआईसी रेंज बढ़ गया है. थर्ड ईयर में आपको दिखाएगा और इंक्रीज हो गया है. व्हाट डू यू मीन बाय इट? सो एमिकासिन का रेजिस्टेंस बढ़ रहा है. ठीक है, सो यू कैन नॉट इग्नोर द ट्रेंड्स ऑफ एमआईसी of every agent, every antibiotic. And overuse broad spectrum agent का वो भी एक बहुत important error है. And not correlating it with clinical picture, as I earlier told you, errors के chances से ही हमने शुरुआत किया था इस lecture का. So that you must be aware of, if your report is not matched with the clinical picture, reassurance is required. ठीक है. So these are the things. What are the role of PharmD in the microbiology based decision? Of course, to interpret reports, to recommend optimal antibiotics, to monitor the response and toxicity, to support the stewardship team. That is what your role is. And this is the key take home message. Microbiology reports guides rational therapy, always correlate lab with the patient condition, patient findings. MIC and antibiograms are the pharmacist tools. Correct interpretation saves further lives. Okay. In fact, it can save antibiotics as well and hospital resources as well. So this is the essence of whole antimicrobial stewardship, guys. I hope it is now making sense to you how important this session is. Yes, just give me a minute. I will be back. I need some water. If you have any doubt, you can put till then in this chat box. Okay, let me take your questions. Treatment option for pan drug. Okay, ये बहुत important question है actually. यहाँ पे हमारे पास कोई भी choice नहीं बचता. We don't have any choice to treat pan drug, but very important is to confirm first the true PDR. Very important. So rechecking the culture, AST methodology, to look at the MIC values, not just the SNR, but you need to check actually the MIC values. You need to rule out contamination, colonization, breakpoints and all. And once it is done, when it is confirmed, then it is the panned drug resistance case, you need to optimize antibiotic. Even if it is resistant, you need to optimize. Like the treatment option, very first is the high dosed, high dose पे beta lactam infusion देना extended period के लिए. So extended or continuous infusion of beta lactam, like you will be maximizing the dose. So sometime it works despite in the resistance pattern. So extended use पे अगर देते हैं, but हमारे पास कोई option नहीं है, that's the reason we are choosing this. Okay, otherwise it is not appropriate. Only pan drug के लिए ये option appropriate है. Extended or continuous infusion of beta lactam, sometime it works even if the resistance is there. Also, combination therapy option is available, like using 2-3 drugs in a combination, like beta lactam को colistin के साथ combine करके दे दिया, tigecycline को polymyxin के साथ combine करके दे दिया, phosphomycin IV दे दिया, carbapenem का double therapy दे दिया. So these are the synergistic killing effect they are doing in the pan drug resistance cases. Also, you can use last resort and the newer agent as well, like organism specific agents भी आ रहे हैं. If the gram negative PDR is there, we have some emerging options. I remember only one gram negative PDR treatment right now, that is cefiderocol. Cefiderocol. Okay, so that is what I remember. So this is how you can solve this type of cases. Is this lecture sounds useful to you? Yes or no? Oh, thank you so much. Yes, I will be available for your doubts. Don't worry. After the certificate as well. Okay, I think we have consumed little bit more time today, but that's okay. I feel good right now because I convey what I wanted to. I hope you are taking it and you are enjoying it and you will practice this. That's where exactly it will make sense. Otherwise, there is no meaning. Next day, you will be going in the hospital asking for the antibiogram. You will read it. You will try to interpret it. You will try to solve it. That's where exactly it is making sense. Thank you so much. Next day, I think tomorrow, again, we will be back with interesting talk. We will have some topic, of course. We have module 6, module 7. AMS is a very huge topic, guys. That's the reason we have come up with the 6-month course on AMS. And we already started. 4 modules are already over. Every Thursday, we have that module. We will be again, that is advanced level. We will be again starting basic level, which was in the yesterday, previous year, I think I have conducted a basic antimicrobial stewardship course. Yes, this is a very huge and interesting topic. Okay, let me give you idea about what is coming tomorrow. Just a minute. Okay, we have lecture number 6 on biomarkers, allergy testing, and immunology panel. So we will talk about CRP, ESR, procalcitonin, cardiac biomarkers, allergy testing, autoimmune panels. Okay, interesting again. Okay, so if no questions are there, we can wind up for today. See you guys tomorrow. Thank you. Thank you so much for joining today. Thank you.